Real news for Americans 50 plus. This is Emeritus News Channel.
Let me now turn it over to Dr. Thomas Frieden, Director of the Centers for Disease Control. Dr. Frieden and his team have been working extraordinarily hard, and his leadership has been fantastic. Dr. Frieden?
Thank you very much, Secretary Duncan. I'd like to spend a couple of minutes saying where we stand in terms of influenza spread in the United States and globally to set the context. Influenza may be the least predictable of all infectious diseases. That means that we need to carefully track what's happening, and we need to be flexible. Influenza continues to spread in the United States and globally. The good news is that globally, the pattern that we've seen does not differ substantially from what we saw in the United States. That means, for example, that we've seen mostly disease among younger people, that most people have had mild disease, although some people have been severely ill, some people have died, particularly those with underlying medical conditions, pregnant women, and others. Flexibility is essential, and local decisions are essential. The guidance we're releasing today will help localities, help states to make decisions based on the best science that are appropriate for their area. What we anticipate is that vaccine will be available in October, and that it so far looks like it will be a good match with the strain that's circulating. What we don't know is whether and when H1N1 will return. It's quite possible that it will come back when schools reopen. It's also possible that it will not. And if it doesn't mean we're out of the woods. Quite the contrary, it means we have time to take additional steps. So we'll need to continue to prepare throughout the fall and throughout the school year and continue to track what's happening with flu in our communities. We also know that in different parts of the country we saw hugely different rates of H1N1. So some places had a lot of it, some places had very little, and if and when it comes back, we expect it won't be the same everywhere. Another reason why local decision making is so very important here. There are also significant challenges that we will face. Not only do we have to track how the virus changes, but we also have to address the fact that we're dealing with a public health system around the country that has not had the level of investment that it should have had in past decades, and it currently faces significant fiscal challenges, and the healthcare system that we have to work closely with that has difficulties with coordination, with information system, and with a focus on prevention. The vaccine will most likely, at least for children, require 2 doses, separated by about 3 weeks or more. And we'll also have seasonal flu vaccine, which, as the Secretary indicated, vaccine is available shortly for. What we're providing today are a series of planning tools for schools. We know from the spring that where there was H1N1, there were very large explosive outbreaks in schools. But we also know that in the spring, we had much less information about H1N1 than we have today. We know more how it behaves. We know more how to control it, what it does and doesn't do. And it is now clear that closure of schools is rarely indicated, even if H1N1 is in the school. There are measures we can take to protect the students, to protect the staff, and to allow learning to continue. It's a local decision based on local information that balances a definite harm of loss of learning, loss of wages, unsupervised children, loss of school support systems and food and other matters, with a possible benefit, which is less spread of H1N1 for perhaps a temporary time period. I was health commissioner in New York City throughout the H1N1 outbreak in this past spring. We had a very large outbreak in New York City, perhaps as many as 800,000 cases or more throughout the city. There were hundreds of schools that had cases, sometimes many cases of H1N1, which we did not close, and which were able to continue teaching, functioning as the important social environment that they are for our students, for our teachers, for the parents. There were also more than 50 schools that we decided to close for a variety of reasons. Perhaps we would have closed fewer if we had known then what we know now. But there were some, for example, children who had special medical needs. They had trouble breathing on their own. In that type of a school, when H1N1 was present, we closed it for a brief period of time, about 5 calendar days. When we reopened it, things were calmer and we were able to deal with it. There are a couple of key things that schools can do that are simple and straightforward. The first is keep sick kids and staff home. If sick people stay out of school, they won't spread H1N1 or other diseases at the school. Second, wash your hands. Third, cover your cough. There are other things that are important, like separating sick kids, making sure that if there are children or staff who have health problems like diabetes or who are pregnant, if they become sick with fever and cough, they should be rapidly treated so that they don't become severely ill. And for certain schools, for example, schools that have most of their students with serious medical problems like muscular dystrophy or severe cerebral palsy, have difficulty coughing or clearing their secretions, they may want to close in certain circumstances. The guidance we're releasing today also has an outline of what we might do if the virus were to change and become more deadly. That's a possibility, and we have to plan so that we would be able to address that kind of situation if it were to arise. In that situation, we would, for example, suggest that local schools and public health officials coordinate closely to actively screen kids when they walk into the school each day. Consider asking people who do have serious underlying conditions to stay home to protect themselves and others, if, and this is only if, we had a more deadly form of flu spreading. Also, to increase distances within the school. Maybe don't bring kids together for joint classes. Maybe have students sit farther apart from one another. And to consider broader school dismissals to reduce the spread of flu. These are all things that we would consider if the virus changed to become more deadly. Responding to H1N1 is a shared responsibility. There are many parts of the federal government working together, and at the state and local levels, we need parents, teachers, students, schools, the business community, the healthcare community coordinating. And that's why we have provided resources, technical guidance, funds to health departments and others to begin and extend and expand that coordination process. There's a crucially important role for states and localities to monitor the situation in their area, to prepare for any medical care needs that might be present, to prepare for vaccination when vaccine becomes available, and to be ready to pivot as the virus changes and as we learn more about it. We're going to respond with the best possible action based on the best possible science. To do that, we'll continue tracking it very intensively. We can't stop the tide of flu from coming in, but we can reduce the number of people who become severely ill from it. We'll now be available to answer a few questions.
Hi, Libby Quaid with AP. Could you please go over the scenarios under which schools may want to consider closing?
In the current context where there is no change, if the flu comes back similar to what it was in the spring, we would say that if you have a school where most or all of the kids have particular medical needs, either they're pregnant, and there are some schools for pregnant teens, or they're medically frail. And that means not just a little bit sick, but kids who have maybe on ventilators or on oxygen, have trouble clearing their lung secretions, that would mean that you might want to close that school. In addition, there may be localities which have so many cases in a school that they decide that administratively they just can't stay open. That would be another example of why you might close at this time. You might also have a situation where, despite telling parents, please keep your kids home when they have fever, a lot of kids with fever are coming into the school. And that was the situation in New York City with a number of schools that we just couldn't ensure that sick kids with fever were staying out, why we decided to close some of those schools when we knew a little less than we know now about flu. One thing that's quite important and is a change in the current guidance is the number of days that we ask people to stay out. Previously, it was a longer period. Now, based on studies both of how flu spreads and of laboratory studies of the flu, we're saying that people stay out for 24 hours after their fever is gone. That's a shorter period. It's more practical, more likely that that will actually be done. So the period of exclusion, as it's called, is 24 hours after the fever is gone, whether or not you're taking medications for the virus, whether or not you're taking Tamiflu.